So just as way of introduction and hello to everyone on Social Work Week, my name is Karen Cook. I've spent 30 plus years working in mental health services, both in local authority and most recently as head of social work in an NHS trust in London. So I'm just going to start off just talking a bit about integration, what it really means, what does being a social worker in those settings mean, and then hand over to Paul in relation to an AMCP regulation. So Vicky, if we can have the next slide, please. So what does integration mean for all of us? I think what it does mean is there's no one right way for arrangements. We've got a myriad of arrangements of integrated teams now in mental health. We've got fully integrated TUPID staff over to trusts. I think you will all find yourselves in different arrangements. But what I wanted to talk about, irrespective of those arrangements, is that social workers need to work together with multi-professional teams, community and voluntary groups, and with the person at the heart of what is provided. And integration really is about cooperating, communicating and coordination of how we work. And we use our social work skills in order to build those relationships. But I'll pose questions to you throughout this session. And my question to you is always around wherever you're based, think about what you might be missing in terms of your own development. So I'm thinking about social workers who are based in the NHS. Actually, have you formed relationships with your local authority colleagues, possibly working in children and families and other areas of adult social care? Do you feel your knowledge and skills on legislation and applying the legislation as high as you'd want it to be? And for social workers in local authorities, do you feel up to date in terms of NICE guidance for mental health treatments? Are you really clear about the roles and responsibilities of the people who work in health and how the NHS works? So there will always be potential gaps depending on the arrangement that you find yourself in. I think the other thing to say on this slide is around relationships. And I was on one of the calls this morning, and Isabel and Lynn were both saying how the changing world of technology that has come into our lives in the last couple of years, how that has impacted on how we form relationships and how we work together. So I've spoken to staff who have started in post during COVID and have never met their team. They've worked at home or they've never met parts of the wider multidisciplinary team. So be aware of how you use your skills to form relationships when it's actually not face-to-face anymore. Next slide, please. So why is social work so important to integration? And I won't be saying anything that you don't know today. So social workers support the social model and social care. We really protect human rights and we think beyond the individual and their needs and have a strength-based community focus. We help coordinate and have a really joined up approach, and that support that transition from hospital and community, and we really focus on individual choice and independence. And I think what's really important, we do with and we don't do to. So I think having that as your framework about what's important for you is really key. I think also to say that no single part of the system can be delivered in isolation, and no one professional group in isolation can deliver holistic care and support. One of the things that we put on the title of this session was around common language. And if we had a group of nurses here, a group of doctors, a group of psychologists, a group of OTs, actually they would all say providing the highest quality care and support is their common goal and the outcome, and holding on to that commonality, I think, is really key in how we build those relationships and how we share common language sometimes in working together. The CMHT transformation that's going on at the moment and has been going on for the last few years is very much talking about place-based, community-focused support. It's talking about individuals' outcomes and supporting people to meet their own defined outcomes. This is language that social work has been talking about for a number of years. So the language in health feels like it's becoming similar to the language of social work. I know we'll have many questions about the medical model, but that's why we're there to challenge that. Next slide, please. So I'm not going to read this quote out, but I just wanted to highlight that last year, the guidance on the support of mental health social workers with working in the NHS, independent or voluntary sector, came out. It was 2020. I'm sort of a year behind. But that gave guidance to organisations that weren't adult social care. It's a really useful document to look at, and it's on the Health Education England website. Can we just go on to the next slide, please? Now, nothing in this slide should be new to you, but it's useful to have, I think, all in one place. And it also can be used with other professional groups, because I think one of the things that we've talked about a lot through Social Work Week, and I'm sure in your teams, is how we promote social work with other professional groups. So I'll just go through this. Social workers aim to improve people's lives by helping with social and interpersonal difficulties, promoting human rights and well-being. There's safeguarding in there. We look at the bigger picture. I think very importantly in the NHS, social workers are skilled in using relevant legal powers to protect human rights. And skilled about bringing change. I think that is really unique to social work. And we work with social networks, families and communities, as well as the individuals. So we ask the person when they come in, what brought you here today? Trying to understand their history and the context that their lives they're living are in. So just have a think when you look at that slide, have a think about what you may want to add or what you might want to adapt to relate to your own job. So how you're explaining your role to others. Okay, let's go on to the next slide, please. So just very briefly, I just wanted to talk about social workers in the NHS. I believe that each trust needs very strong social work leadership to influence strategic development and advocate for the unique contribution of social work. Social workers should have the same access to CPD opportunities and training, and that includes AMPS and AMCP as part of the NHS offer. Every social worker should have good social work supervision, and if a line manager is not a social worker, then social work supervisor should be identified. And NHS Trust should support social work development and have opportunities to take students and develop apprenticeships. I'm saying that as having spent 5 years as a head of social work in a trust where CPD was crucial to recruitment and retention of social workers. And social workers themselves must provide a holistic, person-centred and strengths-based approach in their work with individuals, families and communities, must uphold human rights, anti-discriminatory practice and compliance with the law. Social workers should be clear within their teams what their unique contribution is and what their role is, and be proud to call yourself a social worker and challenge generic terms. So even if you have been appointed to a generic role, there's nothing to stop you saying, I am a social worker, because I think that is crucial to promoting those good news stories about what you do, because you make a difference to people's lives. And then my final slide, and it leads very nicely into what Paul's going to talk about. So if we can have the next slide, Vicky, please. That's it. So AMP and AMCP training. I know that traditionally, funding for AMP and AMCP training has come from local authorities, and some local authorities have supported NHS staff to do that training, but often their own staff take priority. And so I think that NHS staff should support AMHP and AMCP training, and the benefits are that it retains staff. I've heard a number of times that staff have left an organisation purely for the opportunity to do AMP training and feel that they can only get their AMP training within a local authority setting. It supports the whole system of delivery of care. Having sufficient AMPs to respond to requests makes a massive difference to the whole system. We know how A&E's, health-based police and safety, delays impact on the whole system. I think it's really important to spread the knowledge and skills of AMPs and AMCPs across a wide range of teams, and see the role of particularly AMPs as wider than carrying out assessments under the Mental Health Act. And it also increases the number of AMPs in the system. So in terms of what needs to be in place in a trust, and again, this is from experience, because we managed to get funding in my last trust for 8 places from health funding. So you need the agreement of funding of training, often from the education department, and you need an agreement with your HR department about remuneration for AMPs. We went about that by giving an honorarium rather than a gender for change uplift, because it was easier to manage in the system and fairer. You need agreement with local authorities for placement and future warranting. Again, we had the agreement that if a local authority offered a placement for an AMP trainee, that they would then have the benefit of that AMP on their rota for 2 days a week, 2 days a month, sorry. Thirdly, the agreement with the line managers to release the staff to practice and attend required training on an annual basis. Team managers don't always get to understand what the benefits are of releasing someone for 6 months and then losing them for 2 days a month to go on the training. So it's about selling the benefits to team managers. And then finally, having an agreement with local authorities and trusts on liability cover and access to legal advice. This is one of the stumbling points often, because if there's a future claim, even though the AMP is acting on behalf of the local authority, while they remain an employee of a trust, that some local authorities and trusts get themselves a little bit in knots about liability. So I would suggest that sort of lawyers also need to get involved, or to ensure that the contract that's drawn up is clear, and that the organisations aren't trying to resolve these issues when a claim comes in, which is often the case. So that's a very whistle-stop tour of integration, and just really leading into sort of AMP and AMCP training. And I'm going to hand you over now to Paul to talk about regulation.
Brilliant. Thank you, Karen. Can I just check you can hear me? Give me a wave if you can. I was a little sleep.
Yep.
Okay, good. Turn off the mic. I'm determined not to be on mute, as we've done so often for the last 2 years. Yeah, thanks everyone for joining us. And thanks, Karen, for what you've been presenting on. Just very briefly to introduce myself, I'm Paul Peros. I'm one of our policy team here at Social Work England. There are 5 of us, and our job is basically to kind of deliver all the policy that supports, well, pretty much everything we do, really, delivering on our kind of statutory obligations as the regulator. Cunningly, my presentation on policy is buried in the middle of the session, so you can't get away, but I'll try and keep it light and interesting. And actually what I'm going to be doing is drawing out some of the work we've been doing that relates directly to some of the points that Karen's making, in particular on that last slide, but There were some earlier things that she was saying as well, so I will come back to them. So retain them in your memory. I'm not a social worker. I'm a policy professional. I'm married to a social worker, and I've worked previously for the GSEC and the GMC. So my background is really as the regulator, and that's the kind of approach I have. We have social workers in our team, which we're very grateful for. I mean, obviously, we get plenty of input from social workers and also from people who lived experience. Isaac is a member of our National Advisory Forum, so whenever we are doing policy work, we are getting a variety of regulatory and professional and personal perspectives. I'm just going to apologise. There is a fly. It's gone now. If I'm doing this, it's nothing's on fire. Right, next slide, please. I'll start by talking about my recent developments. Brilliant. Thank you very much. So the developments I'm talking about it's been probably my prime task for the last few months. We have two pieces of work in the immediate pipeline. And they are, as you can see, approved mental health professional and approved mental capacity professional approval standards for both of those. So these are two specialisms that we regulate at the moment, and by specialisms I mean areas of specialist work that go beyond your kind of standard social work degree, the entry into the profession, the qualifying award. So these two things are given to us in law. We are going to be publishing new training approval standards for AMP courses, and I'll talk in a moment about what that means. We'll be looking at how we annotate AMPs. If you are qualified as an AMP, how you get that listed on the register. And also, I'll put it on developments, it's not really, but one of the things we're sort of preparing for and looking forward to, in the sense of horizon scanning, is the reform of the Mental Health Act and the promised mental health bill. I'm not sure how fast that is going to be coming to us. After all, the government has promised it's on the way. The other area that we regulate is approved mental capacity professional. Actually, at the moment, it's BIAs, but as I'm sure many of you know, BIAs, best interest assessors, will be replaced in 2023, it looks like, by the new role of approved mental capacity professional, which just fills the same sort of position in the mental capacity kind of framework, but the framework will look different. So the role will change slightly. So we're also producing approval standards for AMCPs. And as you can see, as I have so often, you get confused with AMCP and AMHP. Sorry about the acronyms. They will also be able to be annotated on the register, and we'll be looking at that as well in the same sort of basket of tasks as for mental health professionals. And also we are in quite close contact with the Department of Health on what the implementation period looks like, what the transition from one legal framework that is in place at the moment to the new legal framework will look like. We will come to the questions afterwards. There are a couple of key ones, but I've noticed a couple popping up on my screen. We'll be talking about transitioning, and I'm happy to kind of take questions on that probably offline, because it's not a complicated answer, but yeah, that's something that is taking shape as we speak almost, and there are developments on that. The other thing is, I think someone pointed out quite rightly, and I was coming to that. I should have mentioned in the beginning, not all of these professionals, of these specialists, are social workers. Almost all of them are. We know that because we did some research into it when we sort of started to think about this work. 95%-ish of both specialisms are social workers, but the specialism, both specialisms are open to occupational therapists, nurses, and practitioner psychologists, and AMCPs will also be open to speech and language therapists. So that is one of the key points of interest in this. It's why the work I've been doing relates to what Karen was saying. These are multi-professional specialisms, and that's really unusual, and from my point of view, quite interesting. Next slide, please. I said that we were developing course approval standards, and that has been the main engine for this work. And I'll talk in a minute about stuff that's emerged from that work. We had to do these things because we were asked to do them in law. They're our duty as the specialist regulator. They are not standards for the professionals themselves to follow when they do the job. So they're not like extra professional standards or standards of competence if you're an HCPC registrant, or the code if you're a nurse. They're not the same as the kind of base professional standards that apply to all professionals in your profession. They are the standards that the universities or course providers need to show us as the regulator that they have met in order for us to say, yeah, you can run that course. So they will get approval at the beginning when they first design their training. And in due course, and we don't yet know what the cycle will be, but we will reapprove courses as well. That's something that hasn't been happening for the last few years before we took over as the regulator. Obviously, the pandemic has paused a lot of work, and that was one of them. But reapproval of courses is something we will be bringing in, and that will apply to these courses as well. So that just shows you what the kind of main kind of output that we've been working on is. Next slide, please. Another way to kind of sort of think about it, it's not a perfect analogy, but if you can imagine that the social worker's practice is based on the professional standards, founded on the professional standards, then social work courses are founded on the education and training standards. They are slightly different. It's not to say it's not a perfect kind of parallel, but the basic point is that both of those standards are there to capture the social work values that apply and sort of arise from social work professional identity or specialist professional identity, and they therefore underpin the practice of the course quality and in due course reapproval, as I say. Next slide, please. So I'll just talk briefly about where we are at currently with this work. The consultation document, which is an introduction to what the standards are. You might need to click again. I think we've got a missing face that will fox you for the next slide. Thank you very much. I don't know why that happened. The consultation documents for both of these sets of standards are prepared. Now, we've done them in parallel with the Department of Health, who are preparing their consultation on the new legal framework, the LPS framework that will apply to AMCPs. We've done that. Normally, we'd wait for the regulations to go through Parliament, everything to be in place, all the relevant organisations have the relevant powers, and then we would start. But actually, we thought, well, if we do that, we'll take up quite a lot of time that could be used by course providers to develop the courses. So we've worked in parallel with the Department of Health, developing our standards and keeping in close touch with them to make sure that we're all aligned, that what goes into our standards is we'll work with the new regs and the code of practice that is due. We've done that also on behalf of really the other regulators, the Nursing and Midwifery Council for the nurses, and the HCPC, the Health and Care Professions Council for all the others, because obviously their professionals will be affected. They will all be subject to the same courses, and so we, as the regulator, will be effectively approving courses for nurses. It's a bit odd, but it's worked quite well. I think given the numbers, it's overwhelmingly these are social work flavoured specialisms. Kind of an interesting side point, I did mention earlier, we've done some research at the beginning of this work. We didn't really have a very solid knowledge base about certainly about best interest assessors, and so we went out and asked them how they felt about their specialism, or how they saw themselves, what their professional identity was. And some of the stuff that came back was very illuminating and interesting. We were pleased to see that people see these as advanced social work specialisms, even those who are not social workers. And actually, that was for many of them a reason for getting into the specialism in the first place. They wanted to kind of widen their professional sort of base, if you like, by going into a multi-professional specialism. Anyway, that was a side point. But we've prepared the new standards, and the consultation documents are ready to go. And when the Department of Health is ready to publish its consultation, shortly afterwards, we will publish ours. So you'll have an opportunity quite soon, he said, keeping his fingers crossed, because there have been a number of delays for various legit reasons, COVID and other things. But you will have the opportunity to feed in, and I would encourage you to take a look, keep an eye, and put your answers in, even if it's just one or two questions that we're asking in the consultation, because they will get read. I know it's sometimes easy to sort of assume that there's no point giving a view on these things, but they will all be read. I know that because I'll be reading them all, and my colleagues and I will be coding them, and they will go into the final version of the standards. Those standards will then be approved or be passed in due course, and then we will start to approve courses on that basis. So I definitely encourage you to look out for that. I'm hopeful it's quite soon. but please don't hold me to that, just in case. The last thing that I've put at the bottom of both of those lists, mini lists, is about future supportive regulation of specialists, which is a bit of an ugly mouthful. But that's work that's come out of this. So we obviously started planning to deliver these standards because that's what was needed in the immediate term. Oh, I should have added, actually, sorry, the reason for the timing on the AMP side and the AMHP standards, that is because there's no specific deadline for that. The AMCP role is coming in soon, and we needed to develop those standards in order to support the implementation period. AMP courses are already in place, and they're already being regulated, and they're already being, approved if new ones come up. It's just that when we took over as the regulator, we inherited those standards from our predecessor, the Health and Care Professions Council. And so we just wanted to refresh them, so they've just been slightly updated. It's not a massive change. So what we've done, I think, for our convenience, for efficiency, really, was to pin them together. We said if there was any particular reason to move faster with the AMP courses, we would, but we haven't had any particular reason to. So we're going to publish them all together because a lot of the kind of interest groups are the same, and I'm sure many of you will be interested in both. So that's why we're publishing the AMP standards now, even though there's no sort of apparent trigger for that. It's very obvious why we're doing the AMCP standards, I think. Anyway, sorry, back to my point I was making was about the horrible phrase future supportive regulation specialists. Now, Karen mentioned a few things in her presentation, which I really want to build on in the work that we do as the regulator. She talked about professional identity. She talked about I've lost the slide. I have them here, but on her last slide about knowledge and skills, spreading knowledge and skills from AMCP throughout teams. We appear to have lost the slides on my screen. I hope that's not true for everyone. Anyway, I'll carry on. Hopefully they already appear. Part of being able to, thank you very much, part of being able to spread and infuse teams with skills requires a strong professional identity. That is partly present, but it's kind of more by accident than design, and we can see that changing over time, especially as the proportion of social workers may go down. And so we want to momentarily muted. I hope I'm back now. Next slide, please. The first sort of step, the kind of basis for regulation, is annotation. So if you are in either of these specialisms, you will have you're entitled already, actually, to add that to your register entry. So you can contact us and we can put that on your register entry. Now, we do need to make some changes to how that works because it's not quite perfect at the moment. The rules around that were drafted before we went live as the regulator, and we just need to make sure it's fully useful. But we want to use this as a basis for giving us a way in, if you like, to regulating specialists in a way that is supportive of their professional identity and therefore, their ability to kind of do all the things that Karen was talking about in terms of existing within teams. Sorry, I'm spotting some interesting questions, which is distracting as well. Annotation should recognise skills and expertise as well, and that's a key point. At the moment, it's you can be annotated if you're qualified, and that's fine. But I would like annotation to be an indicator, like a symbol that someone has got a proper expertise in a proper specialist area. I think that's sometimes lost. I really want social workers to kind of feel that they can own their own expertise as a discipline, almost, as well as a profession. I'm not saying you're equivalent to a brain surgeon, but if you think about a medical specialism, I'd like some of that kind of cachet to come your way, because a lot of the stuff social workers do is incredible, and a lot of the stuff you do in these particular specialisms, at risk of normal people can't do it. It's really advanced, hard, expert work. So we want to kind of build on that. Next slide, please. And these are the kind of questions that we're going to be asking. So in the immediate term, you'll see the consultation on the training and approval standards. Please respond to those. And arising from that, we are going to be saying, how do we best underpin specialist practice, as is the case, as you'll see from my little people and documents there, as is the case for practicing social workers as specialists, as registrants, and course providers through the professional standards. What is it that specialists need in order to build that kind of advanced professional identity that will help you to deliver what Karen talked about, that sharing of expertise, that kind of sort of I've lost the word, but that kind of presence, especially in the interprofessional world, and especially because they are multi-professional specialist areas. I don't want to kind of go on too long, because as a policy wonk, I can get a bit boring about this. I find it really exciting and interesting. I hope the questions have made sense to you. I would just say we're not wanting to add in fitness to practice requirements, additional things you have to do or not do in order to, not be told off by the regulator. That's not what this is about. This is about beefing up these specialist areas, if you like, so that their, social workers are able to use their specialist status, for example, in discussions about appropriate supervision for specialists and experts in, from employers. At the moment, it is all questions, but I'm really interested to hear your views. So I really would welcome contact from anyone who's interested in finding out more about this and perhaps being involved as we move forward. Ultimately, it is easy to get lost in all the detail and read lots of reports and write lots of reports, but this is based on people helping people in very difficult situations. And I'm pleased to say that we've got Isaac, who's been part of our National Advisory Forum. He'll be speaking to us next. There's a video about some of his experiences. So that is coming up next. And I think that's all. Just checking. Yeah, that's my last slide. So thank you for that. I hope that was clear. Not too many bleeping. There are some questions, and I have been keeping one eye on them as they come up. There are lots of interesting questions, so I do hope to take some of those at the end. And if not, we'll do some written responses for you. But yeah, thanks for the questions. Over to Isaac and Vicky.
Yeah, I'm just coming in here, Isaac, if that's all right. So just wanted to introduce Isaac, who's a member of our National Advisory Forum. Isaac we've recorded an interview with Isaac talking about his lived experience of having social workers and the importance of having good social workers in mental health. So it is a video, but as you can see, Isaac is around, and I know we'll be looking in the comments and reading and maybe responding. So just going to play the segment, and hopefully you'll be able to see what's been contributed. Hi, Isaac. Thank you so much for joining us. Just a few questions, if that's all right. First of all, could you give us a little bit of an introduction?
Sure. So my name is Isaac Samuels, and I live in the east of London with my husband, and I have 4 dogs. I am currently really involved in lots of stuff around co-production, so I work with lots of national organisations, sharing my own experiences of mental health to help organisations understand the needs of people like me. I work at a policy level, trying to help systems and organisations to really embed what is important for people with mental health challenges. I've lived with severe and enduring mental health challenges for over 25 years. I probably would say that I had mental health challenges as a child, but was diagnosed in my early teens with bipolar affective disorder. And I've had loads of diagnosis since then, but I have bipolar, and I live with mental health every day.
Thank you so much, Isaac. And I was wondering if you'd be able to tell us about the impact that social work has had on your experiences.
So it's a really big question, but I'll probably start back in my early journey. So when I first come into contact with social workers, particularly mental health social workers, I was really conscious that when I had my first breakdown and I was in hospital for a long time, that there were all of these professionals involved in my life that weren't necessarily talking to me or really understanding what was important to me. So lots of people, including the social worker that I had at the time. So obviously when you're sectioned, that social worker is involved in that process. And it was a really traumatic time for me. It was, you know, being sectioned in the middle of night, police, social worker, doctor, all of those things, trauma, ending up in hospital for 9 months, trauma, and never really saw the social worker that sectioned me again. Then I had a social worker whilst on the ward, and they really made a lot of decisions about my life and didn't include me in those discussions or decisions. And I think what I would say to my younger self now is to have more confidence about speaking up. And I remember being told by a social worker, and I've had social workers involved in my life for a very, very long time, by a social worker about 5 years ago, that she really wanted me to leave services, mental health services, because nobody should be accessing mental health services for the rest of their life. That was the most scariest thing for me, because I'd been told 20 years earlier that I'll never work. I would need lots of support. I would probably never have a relationship.
Hi, can everybody make sure they're on mute, please? Vicky, we've lost sound on the video.
Okay, sorry about that.
A life with purpose. Really wanted me to.
Did that work?
To leave services.
Yeah, it's back now, thank you.
Services, because nobody should be accessing mental health services for the rest of their life. That was the most scariest thing for me, because I'd been told.
Sorry, we've lost sound again.
I need lots of support. I would probably never have a relationship, and I had very few choices. And it took me a really, really long time of really struggling within social care, mental health services, to really find a life with purpose and meaning. And for a long time, social workers were not very good in my life. And then I happened to be allocated to the social worker called David, and he did something which I think you as a social worker probably do all the time, but he did something remarkable. And I was like a bit cynical when he turned up at my home and he said, "Oh, I'm not going to do an assessment. I'm not here to do an assessment. Just want to find out who you are, what is important to you." And I really thought that he was a bit strange. I thought, why would I was expecting this assessment. And for me, my previous relationships with mental health social workers were one of them having, being sectioned, having to go and see a social worker, because I was on a thing called CPA, which was a care program approach. And it meant that you'd have to go to a community mental health team. I used to go once a week in the beginning, then it was every 2 weeks, and it was monthly. But it would always be in the middle of the day in this really awful building with lots of unwell people. The social worker would always be late. The consultant would always be late. Nobody really spoke to you as a human being. And so I was like really, really jaded, angry, browbeaten by the whole system. And then this social worker comes along, and he and I just kept on meeting and having coffees and chats. What I didn't know at the time, and I do know now, he was doing his assessment, but he was actually just getting to know me. And what he did was he identified that for me, there was a unmet need. There was not only my mental health, there was my physical health, because I lived with a lot of physical health challenges, and having a bit of support could make all the difference. And he said, "Oh, there's this thing called a personal health budget." I was like, "I've never heard of what a personal health budget is." He said it's pot of money where people can self-direct their own support. I was like, I don't know what self-directing your own support means, let alone would I want to do it. I was like, I don't want to do that. It sounds too complicated. But we spoke about it, and I got a personal health budget, and this was, oh gosh, about 15 years ago, and I bought a dog. And that dog absolutely changed my life, because what it did is it gave me purpose. It gave me something every day to wake up and open my curtains. And I, as being someone, when you live with anxiety, depression, and this sense of, and people don't really feel comfortable talking about this, but when you want to just be dead every day, having something to wake up to made all the difference. So bought this dog, started to get this routine, and those thoughts and feelings became quieter in my head. And I felt like, oh God, there is a little bit of a glimmer of a hope that I could have a life that people around me had. And at the same time, he supported me to get a direct payment for a personal assistant to come and just help me out. And I went off and I did lots of things, and I just felt scared, but I felt like a new person. I felt like I had all of these opportunities at my fingertips. But I was also really scared, because I felt like they were really fragile at times, because I didn't really know, I didn't even know who I was, let alone what the future looked like. And I started to get involved with different things. And I would say that I had more people in my life at that point that were professionals than friends and family. And I was really medicalized. So the things that were important to me were like medication. I would spend a lot of time going in and out of hospitals. And through that support that I got from David, I was really able to break that cycle. So I was able to stay at hospital for a year, and that was a big milestone for me. I was able to go to therapy, and I was in therapy for 3 years, and it was difficult, but actually just having that stability, just having someone to be able to help me on a day-to-day basis, having the dog, which were really, really small things. And when I think about how much resource and money and time that was wasted by me, everybody, like everything was just a missed opportunity, to the point that I now know that that dog saved my life. And that when people enter mental health systems and services, it's often really difficult to find a way out of those. And it's really difficult to find your new identity, because you have like this mental health crisis. You end up in a place. And it was really funny. I was in like a hospital, and I would be fighting to get out of hospital. The minute I was out, I was fighting to get back in. It just didn't make any sense. There was all of these really big problems that happened. So he was a really good social worker. He listened, and he had qualities that I think social work is about. So he was someone about social justice. He was someone that advocated for the rights of people. He believed in, and the reason I did work that I do today is because of him, because he introduced me to like self-directed support, the independent living movement. And the reality is that when you live with a condition, you might need a bit of support, but actually you can have the same life as your peers. You just need a bit of support to get there.
Thank you so much, Isaac. That's a really good and hopefully helpful explanation of what social work can be to someone and the difference that good social work can make. So thank you so much for that. Really appreciate it. Thank you. Thanks. And I just want to thank Isaac for sharing his personal story with us. I'm going to on share now. I think you're on the screen now, Isaac, I hope. And thank you so much for sharing that. I think it was really powerful. We do have a little bit of time for some questions, and I know Isaac as well. Do please put your feedback into the chat, because I know obviously you can see Isaac's here with us. But if there are any particular questions coming up for any of the participants, then we can have a look. I think there's been a few around the process of just looking about accessing CPD as an NHS member of staff, when NHS England doesn't classify social workers as AHPs and are excluded from certain training opportunities. And I think maybe Karen can speak to that a little bit, because that's an experience I think that can happen within the NHS sometimes, that not quite sitting in one place or another.
Yeah, thanks. And I've been looking at the chat as well. There's also quite a number of comments about how some social workers in the NHS have had a range of jobs in a range of settings and have really valued it. I think that's something that's really important. I think social workers throughout the NHS is really crucial. I think it does depend on your trust and how they use their education money. And we were able to see the pot of money that came into the trust as a whole, and I had quite a sympathetic head of education who recognised that they weren't doing enough for social work, and that's how they were able to put funds aside for both currently sort of best interest assessment training and also sort of AMP training. But I would say if your trust isn't funding for CPD, you have to identify it through your appraisals. If there is a head of social work, you need them to start articulating it, and keep pushing, really, because I think I sit on the, and Paul sits on the social work group with Health Education England, and we constantly push for social work training within the NHS, but recognise it's not as easy in every trust, and in the same way that there's been discussions about gradings and funding, I think exactly the same, that there isn't a consistency that we would like to have across the NHS.
And I'm just going to come in because we've not really got much time, but there was a question that came in from Zoe that I think maybe you can all answer maybe in a minute, about any advice for student social workers entering mental health social work. And I think you'd all have a quick comment on that. I don't know, Isaac, do you want to start? Do you have any, what would you advise somebody going into mental health social work?
For more people to go into mental health, because it's a great job, great opportunity to make a difference and support people to regain their lives, or to find a different way of living. I think it's a wonderful opportunity. So I love mental health social workers.
Oh, thank you so much. Paul, do you have any advice for a student coming into?
As far as students or a kind of a opportunity for a plug, really, but we're consulting on the approval standards soon. We'll be consulting on how we, as I say, supportively regulate AMPs in the future. Stay in touch with us as the regulator and tell us what you think. It's really important for us to hear the voice of, AMPs, new AMP, old AMPs. So, please do keep in contact with us, because I want to, be able to develop policy that really works for AMPs and helps them to deliver the best care that they can.
And Karen, finally, advice for student social worker wanting to go into mental health.
I would echo what Isaac said. Having been a mental health social worker for the last 30 years, I would say it's so fulfilling. Getting it right, holding on to your social work values, never losing sight of the person whose life you're in. And sometimes it's a privilege to be in other people's lives and be there at that point of crisis. And you might say or do something that you might not think is making a difference, but often it does. So I would say, and in terms of advice, actually it doesn't matter where the team is. Actually, it's whether you're in a team that's supportive, whether that team shares your values and the passion for holding the person at the centre of everything that team does. So don't think about who the employer is necessarily. Think about the team and think about why you're there. And you will get as much satisfaction out of a career, I hope, as a lot of the people that are on this call today.
Thank you so much. And
sorry, yeah, just to add in, I echo what you both been saying actually, but on that last point, Karen, I'm really keen for social workers to really own that you're experts in a really important, difficult, demanding, specialist area. So take that with you, and as say, be assertive. You know, bring your values into the team, integration and person-centeredness. Everyone sees them as good things, but it's social workers who really carry the flame. So, you know, we want to kind of enable that, and I really would urge you to remember that you can do that. Be present.
So, I mean, I just want to thank Isaac, Paul, and Karen for giving us your time for a fantastic session. We have recorded this session, and it will be available shortly on the YouTube channel. And we really hope you've enjoyed it. I know there's been a few technical hiccups, but thank you so much for bearing with us. And if you could complete the survey that Chelsea has linked into the chat, that would be really helpful for us to take feedback. And there is an email address in there as well. And remember, for social workers there, that this can be used as part of your CPD requirements. Talk up to your team about it, and it can be part of your peer reflection. And just thank you so much for this, and I hope you enjoy the rest of the week with us. Thank you.